So I'm going to be talking to you guys about paraphilia. I want to first take a look at the difference between paraphilic desires and DSM-5 criteria. So DSM defines a normophilic sexual interest as an interest in genital stimulation or preparatory fondling with phenotypically normal, physically mature, consenting human partners. So to consenting adults, engaging in genital stimulation, normophilic. So any other sexual interest is considered to be paraphilic. So it's important to recognize the difference between atypical sexual behavior and an actual mental disorder. The DSM-5 distinguishes this difference between the atypical sexual interest and mental disorders with two different elements. So in order for it to be a diagnosis of a paraphilic disorder, the person needs to feel distress about their interests, and that's not merely from distress resulting from society's approval. So it needs to be something that they're personally distressed about. And then the other piece of that is that their sexual desire or behavior involves another person's psychological distress, injury, or death, or their desire for sexual behavior involves unwilling persons or persons unable to have or give legal consent. So looking at pedophilia, obviously a child's not able to give consent to an adult, and we have to also consider those things that are in this category illegal. So that's how to differentiate between the paraphilic interest and an actual diagnostic criteria. So the DSM chapter on paraphilic disorders includes 8 conditions. Voyeurism is observing an unsuspecting person who is naked or changing or involved in sexual activity. The exhibitionistic disorder is the exposure of one's genitalia to an unsuspecting person. So it's to be somebody who flashes. Fetishism is either the use of non-living objects or a specific focus on a non-genital body part. So a common one of these that's typically discussed is having a foot fetish. Frauduristic disorder is touching or rubbing against a non-consenting person. An example of this would be if you are on public transportation and somebody gets sexual arousal from rubbing up against you. That would be frauduristic disorder. And then pedophilic disorder, fantasies or sexual activity with a prepubescent child or children. Sexual masochism is the act of being humiliated, beaten, bound, or otherwise made to suffer. And then on the flip side of that is sexual sadism disorder, and that's the physical or psychological suffering of another person. And then you have transvestic disorder, and this is sexual arousal from cross-dressing. So again, looking at the two elements, where transvestic disorder on one end would be, are they having great distress because of the cross-dressing? Is that bothering them? Because maybe they can't get aroused without that piece. And then on the other side, where you're looking at pedophilic disorders, if they're acting out with a child, that's illegal, and we have to obviously report something like that. So there's different pieces of that. Brief history of paraphilia. In the end of the 19th century, it was regarded as a medical phenomenon. And then Freud, his early theory of sexuality, is the basis for studying sexual deviance, and that led into other studies, psychoanalytical studies of sexual deviance and leading into paraphilia. The end of the 19th century, they were doing sterilization without consent for criminals, mentally ill, and sexually delinquent individuals. By 1985, 19 states in the U.S. still retain the legislation of forced sterilization. After World War II, what was considered normal sexually was what was defined by the traditional gender roles at that time, so 1940s and 50s, and whatever was associated with the nuclear family. So going into the original DSM in 1952, homosexuality, obviously not part of the nuclear family, that was classified as a sociopathic personality disorder and then reclassified in DSM-2 as a sexual deviation. The term paraphilia was actually introduced in the DSM-3, and it was considered a less prejudicial and less judgmental way of describing sexual deviation. So as previously discussed, initial treatment approach was actually surgical castration. So that was used on sex offenders. That started in 1892, and it actually showed to be very effective, understandably so. So during the 20th century, that became more widely spread across Europe and then into the US. And surgical castration was actually legally reintroduced for sex offenders in 1996. It was in the 1940s when they made some attempts to treat sex offenders with anti-libido medication. And then a more recent development in that is luteinizing hormone-releasing hormone agonists. It was in the 1960s that they introduced behavioral therapy for treatment of paraphilias. And then aversion therapy was applied for homosexuality as well as sex offenders. And then in the 1980s, that began to be considered unethical due to societal changes and norms. But I do know that that is still being used by some therapists from what I've heard. Cognitive behavioral therapy is currently the most commonly used treatment option, and plenty of research shows that it has a reduction in recidivism for sex offenders. So I found it interesting that I really couldn't find a whole lot of family systems perspectives on paraphilia. There was one article that sounded very great, and I just had the access of the abstract that was not available through Bethel, so I found that interesting. But I did come across this really interesting pilot study that was looking at families that have paraphilia kind of seen throughout the generations. There's been a number of models that propose that negative experiences during childhood are precursors to sexual offending, with or without the piece of paraphilia. So any negative experiences in childhood regarding sexuality can lead to sexual offense in adulthood. But there was a biopsychosocial piece to that. So biopsychologically, assessments have shown that rapists and violent pedophilic males have a distinct pattern of sexual arousal compared to control groups. And the effectiveness of hormonal organic treatments for male sexual offenders further supports the role of the biological factor in the modulation of sexual deviant behavior. So there's that clear biological piece. Something that was interesting throughout the family genograms, the sexual genograms that they were looking at, is that those families with pedophilia, you saw that passed down from generation to generation, as opposed to families with other paraphilias that weren't associated with the pedophilia. Other paraphilias can be passed down, but you would not see the pedophilial aspect with other paraphilias. So if you look at a family genogram of pedophilia, you'll see that clearly. And with paraphilias, you won't see acts on adolescents or children. So the results from this basically suggested that there is an influence of psychosocial as well as neurobiological factors in the development of deviant sexual behaviors. But the consensus of all of that was that we really need some more research to nail down what's causing this sexual deviation. They have, correlations, and there's an understanding that we do see this as a pattern throughout generations, but there does need to be some more research that goes into this. Looking at paraphilia from a clinical perspective, something we want to consider is comorbidity. So it was discussed that it was pretty common for there to be comorbidity associated with paraphilia. And this one in particular study, as shown on the left, shows that major depression and bipolar disorder are pretty common associations. Another one was, one of the most common is another paraphilia. So you may have somebody who's interested in voyeurism and fetishism. So looking at what other things may be associated with that. If you see somebody coming in with paraphilia or a sex offender, what are some other pieces that could be going on as opposed to just focusing on that paraphilic sexual behavior? Because there may be some other things that we can address or treat that may coincide with their paraphilic behaviors. Looking at CBT as a treatment option for paraphilic disorders, there are basically two levels that they discussed. One level is somebody who's just struggling with desires and fantasies that's causing them distress, and that CBT treatment would look very similar to something that would be like substance abuse, and it discussed motivational interviewing, dealing with maladaptive thoughts and behaviors. So then it went into the level 2, and this was particularly discussing sex offenders. And those techniques get much more specific. So there's two sides to it. The first one is about decreasing inappropriate sexual arousal, and then the flip side of that is increasing appropriate arousal. So on the decreasing side, you have covert sensitization, and that pairs urges and feelings that lead an individual to engage in a deviant act with aversive images. So for this, they would have the individual engage in a deviant act with aversive images, and that would reflect aversive consequences of continuing the deviant behavior. And then the treatment is conducted by having the patient record the session, and then the therapist discusses it in individual or group sessions. Satiation is basically a technique that works on decreasing deviant sexual arousal by making the deviant fantasy boring. And what they do to accomplish that is they have a patient masturbate at home to non-deviant adult fantasies until ejaculation has occurred. And it works by pairing the deviant sexual fantasy with the aversive task of masturbating for 55 minutes post-orgasm. And then systemic desensitization is a technique that aims at decreasing maladaptive anxiety by pairing relaxation with imagined scenes depicting anxiety-producing situations. And then on the other side is the increase of acceptable arousal and sexual behaviors. So the first one is orgasmic reconditioning. So that is where you have the client masturbate to orgasm while fantasizing about or watching normative sexual behaviors with adults. And then there's fading, and fading aims to change sexual fantasy and arousal towards more acceptable interests. So what they do is ask them to, while they have sexual arousal with one of the abnormal or paraphilic desires, they then have to be cognizant of that and shift that desire and fantasy into a more acceptable interest. So it's changing their association of sexual desire and fantasy into something that's more acceptable as opposed to their deviant sexual behaviors and desires. On the psychopharmacological side of treatment, there are a few options. SSRIs, which look at reducing sex drive and increasing serotonin. Hormonal treatment options, they used to use estrogen, but that had a risk of increased chance of breast cancer. So now they use steroidal anti-androgens, which reduce the level of testosterone. MPAs bind to the testosterone globulin, so it decreases free testosterone. Cyproterone acetate is a synthetic steroid that binds to androgen brain receptors and acts as a competitive inhibitor of testosterone and DHT. And then GnRHA, it downregulates secretion of luteinizing and follicle stimulating hormones, which is what actually stimulates testosterone. So all along the lines of either reducing sexual arousal or sexual drive or reducing testosterone, which has similar effects, is important to consider when it's appropriate to use medication for paraphilic disorders. There are some negative effects when you're talking about using hormonal therapy, and there is a chance that not all patients are compliant with their medications. So just some things to consider when looking at treating with any sort of pharmacological therapy. Expounding on SSRIs, because that seemed to be the most commonly used pharmacological treatment option. The study that I looked at was looking at the use of SSRIs in the prison population with sex offenders. And what they discussed was that the SSRIs shouldn't really be used alone, but done as a comprehensive treatment plan, which includes psychotherapy. And what they found was that using SSRIs with therapy was very beneficial because reducing the libido actually made the offenders more responsive to therapy. So taking away that urge and desire for the sexual portion of that allowed them to focus on the therapeutic portion. And it was found to be most effective with offenders who had difficulty resisting the urges and reduced their desire to act on those urges. The SSRIs are beneficial in three ways. As previously discussed, they inhibit sexual interest. They also reduce impulsivity, which can be an element of the paraphilic disorders. And they also they decrease the obsessive compulsive symptoms that can sometimes affect how the paraphilic disorder is being acted on. And the discussion here was that the treatment, in this case CBT, combined with SSRIs, reduced the risk of recidivism by 1/3. So using those together can be very helpful and prevent reoffense. Just highlighting some other considerations for therapy with this population. Clients need to be made aware of our obligation to report, given that some paraphilias are criminal in nature. They just need to know that up front, that if they disclose harm to others, that's something that we have to report, just so that's upfront and honest from the beginning of therapy. Then looking at when we're treating them, it is important to kind of consider and discuss their sexual history, considering the familial aspect, and then how the negative experiences in childhood can affect their adult experiences of sexuality. Doing something like a sexual genogram would be very helpful to see what's been passed down and what they consider normative in their family history and in their past experiences and how that's affecting them currently. If paraphilic disorder or paraphilic activity or desires is disclosed, there are a couple things for us to look at in assessment for the level of risk and danger. If we're working with pedophilia, for example, and they express a desire for that behavior and then express a desire to act on that behavior, we're trying to assess what that level of risk is to others. Do they have access to children? Is it something that they've really thought about? Have they have a plan to do that with a child that they're around? So asking those questions and figuring out how, what is that level of risk and danger to another person in a case like that? And then the other piece of that is if you take something like sadomasochism, where a big element of the desire and sexual arousal stems from power differential, and it stems from the risk of hurt and injury and harm. So that is a key aspect of the desire. But if we were working with a client or a couple in that scenario that's participating in sadomasochism, something that we might want to discuss is what safety precautions are in place. Where are the boundaries to discuss and assess, what is the level for serious risk or serious danger and harm. There is the asphyxiation piece where they have sexual arousal from choking and has that couple put in safety measures so that it doesn't cross over into dangerous territory. So having those conversations, if we're working with them as a couple, let's discuss how to put in place some safety measures for them. And then determining if there are victims associated with the paraphilic disorder. So a good indicator of future behavior is past behavior. So if there has been victims in the past, it alerts us to be on the lookout for changes in something that is just a fantasy to, I want to act on this again. And that just allows us to be aware. And same goes for those who have already been diagnosed with the disorder or have are previous sex offenders, for us to have regular assessment, be on the lookout for where they're at currently, what is their mental state, is it something that they're going to want to act on again, and for us to be able to have early intervention that way to hopefully prevent any danger to, or harm to others or to themselves. And then maintaining non-judgmental stance during our inquiry of these behaviors and thoughts and desires, because that'll help us to maintain a therapeutic alliance with our clients. And in this case, it's very important because if they feel comfortable talking to us about that, it allows us to be able to take steps and measures and intervene early on, where if they don't trust us, they may not tell us, I'm having these desires, because they're worried that we're going to judge them for that rather than listening and being able to help them. And then on the other side is with those who don't have criminal activity, again, going into sadomasochism, for example, if the couple's working together and they both desire that, what are their personal goals, and putting our own bias aside and focusing on helping the clients work towards their goals. And if they don't agree, we come together and help them come up with a solution together, but not having our own bias on what's right or wrong in that situation. And that is it for my references, and thank you.